Welcome all to our G-ECHO hosted by Gastro Foundation in association with Project ECHO, University of New Mexico. Today's topic will be small bowel intestinal bleeding presented by Simon Veenstra from UCT Groningen. I'm Shiraaz Gabriel as the chairperson from Tygerberg Hospital. Simon, you can share your screen.
Sure. Sorry. All right, can you see my screen?
Yeah, go for it.
All right, good evening, everyone. I just want to see if I can move this out the way. Sorry. Good evening, everyone. As Dr. Gabriel has mentioned, my name is Simon Veenstra. I'm one of the fellows at Groningen Hospital, and I'm going to be presenting small bowel bleeding this evening. I'm briefly going to look at some of the definitions, go through some, look at the epidemiology and risk factors. And then I think probably the most important part of this is probably regarding an approach to small bowel bleeding. And then we're going to look at some of the investigations and causes, and then hopefully finish everything in the allotted time. So some of the traditional definitions regarding small bowel bleeding, the term that has mostly been used in the past is that of obscure GI bleeding. And this was defined as bleeding of uncertain cause after non-diagnostic upper and lower scopes, and often was used synonymously for a small bowel bleed. This was further subclassified into obscure overt and obscure occult, with overt being visible GI bleeding, either to the patient or to the physician, in the form of hematochezia, melena, or maroon stool, but with no obvious cause on any of the above investigations. And then occult, where the patient had basically presented either with an iron deficiency anemia, or there was a positive fecal occult blood test. So no overt or visible blood seen in the stool. However, the AGA brought out some guidelines in 2015, which proposed a name change to small bowel bleeding, based on the fact that we've had quite a marked improvement in the technology available to us to visualize the small bowel, and detection rates of small bowel lesions have improved dramatically. And so they proposed that the term small bowel bleeding be used, and when you'd performed a negative bidirectional endoscopy and then suspected that the bleeding was from somewhere in the small bowel, that then be termed suspected small bowel bleeding, either overt or occult. And that obscure GI bleeding was then reserved for bleeding where there truly was no source identified, despite the latest imaging and dedicated small bowel evaluation being performed. There are also some anatomic definitions. So I think we're all familiar with the upper GI tract and lower GI tract, which was divided by the ligament of Treitz. And obviously bleeding from either of those regions was termed as such, either upper GI bleeding or lower GI bleeding. However, again, I think as we try to be more sort of precise in medicine, they've come up with a term, or not come up with, but they suggested labeling the area between the ampulla of Vater and the ileocecal valve as mid-GI bleeding, and that then sources above the ampulla of Vater, that would be then termed upper GI bleed, and a lower GI bleed from below the ileocecal valve. With regards to the epidemiology of small bowel bleeding, it's still a relatively rare cause for a GI bleed, with only about 5 to 10% of all GI bleeds being from the small bowel itself. And the majority of GI bleeds come from either the foregut or the colon. However, in the traditional obscure GI bleed, when you look at those all those bleeds, then up to 75% of that could a source was found in the small bowel. So a prominent source of an obscure GI bleed. So sorry, I hope that makes sense. So when you look at obscure GI bleeding, then 75% of that is found in the small bowel. And there are various risk factors that can predict whether or not you are going to, in someone who you suspect has a small bowel bleed, whether or not you are going to have a positive investigation. And so besides some comorbidities like hypertension and diabetes, some of the more significant factors that are associated with a positive test include anticoagulant usage, chronic kidney failure or chronic kidney disease and liver cirrhosis, as well as being on hemodialysis. These were all highly predictive of vascular lesions and in the setting of an overt bleed. NSAID use and PPI use was highly predictive of ulcerative lesions. We know that NSAIDs have deleterious effects on mucosa, not only in the gastric mucosa, but all along the GI tract. And PPI use as well, interestingly, is also associated with a higher risk of ulcerative lesions in the small bowel as well. And that's thought to be due to dysbiosis caused by the reduction in gastric acid. In occult bleeding, again, liver cirrhosis is highly predictive of finding a vascular lesion in occult bleeding. And then again, your use of aspirin and PPIs are highly predictive of finding ulcerative lesions on your testing as well. So in terms of guidance, so there was sort of two main societies or that I could find that brought out sort of specific guidance on an approach to a suspected small bowel bleed. The first was the American College of Gastroenterology, which was a dedicated guideline to the diagnosis and management of small bowel bleeding. But this was published quite a long time ago, in 2015. And there's a few differences between that and the other guideline, which is from the ESGE, which I'll show shortly. But in here, they suggest, whether it be occult or overt, that one should consider or could consider a repeat endoscopy, and only if that was negative, then to proceed with dedicated small bowel evaluation. If you were concerned for any obstruction, then to first perform cross-sectional imaging, either with a CT or an MRI, and then proceed to video capture, or if no obstruction was if you weren't concerned for any obstruction, then to proceed directly to video capsule endoscopy. And then obviously, if there's any positive findings on that, then to proceed as indicated with the specific management, depending on what you found. One would then, if negative, one could then approach either you could either use a conservative approach with a watch and wait, or if there was recurrent bleeding, then to consider repeating the above, or continuing with more specific investigations like a Meckel scan or specific red blood cell scintigraphy, depending on the case. They also give guidance on how to approach an unstable patient with a brisk and massive suspected small bowel bleed. Obviously, one would stabilize the patient first, and then in this case, they recommend CT angiography as your first port of call. And obviously from there, one could move on to conventional angiography, if positive, to perform embolization, and if negative, then to proceed with further investigations like enteroscopy or surgery. With more subacute bleeding, in a stable patient, one could consider video capsule or cross-sectional imaging, and if that was positive, then to proceed with endoscopy and treat accordingly. But if negative, then to consider other investigations like red blood cell scans or surgery, intraoperative endoscopy, etc. I think the ESGE guideline, which isn't it was brought out more, it was looking at small bowel capsule endoscopy and device-assisted enteroscopy in small bowel disorders as a whole, but they had a subcategory on suspected small bowel bleeding. I think this is a much simpler algorithm to follow, and was brought out in 2022, so more recent. But here, I think the main difference is that the first line of investigation after a negative upper and lower endoscopy is to perform a video capsule, and if positive, obviously then to proceed with specific management, and if negative, then to pursue a wait and see policy, and only repeat workup if there was a recurrence. So I think the second look endoscopy is a question that kind of comes up quite often in our daily clinical practice, and on whether to perform it or not, or move straight to other modalities of investigation. And obviously we have guidance from the ESGE that suggests that we should move straight to video capsule endoscopy, but is there any evidence for or against? And this is specifically looking at upper scopes. And so these were trials that looked at either video capsule or push enteroscopies or device-assisted enteroscopy, and then looked at how many of those positive results had lesions that were then within reach of the small of your basically of an upper scope. And we can see that the range is quite wide. It ranges from almost 3% to 65% of lesions which were found within range of an upper scope. This outlier here at the bottom, sorry, can you see when I move my mouse?
Yeah, we can see.
Okay. This Claire Gill study, though I think is a bit of an outlier, it was looking specifically at patients older than 65 with ongoing iron deficiency anemia, so not overt bleeding per se, but the range is quite wide, and ultimately they state that there's not sufficient evidence at the moment to recommend routine second look endoscopy, but this should be based on a case-by-case basis. And I think this is fair. I think there are a few things that need to be looked at when you decide on whether to go through with a second look endoscopy or not. You need to look at when the last exam was performed, the quality of that exam, what were the findings, and obviously the nature of bleeding before deciding on whether or not to do that. So with regards then to video capsule endoscopy, which is obviously recommended as your first line investigation after your upper and lower scope, it's got a very good diagnostic yield of almost of 55 to 62%. It's consistently superior to push enteroscopy, CT enterography, CT angiography, and intraoperative enteroscopy. And it's as good as device-assisted enteroscopy, in evaluating and finding the bleeding source. Importantly, its yield is highest when performed within the first 48 to 72 hours, but this but the yield is still very good up to 14 days. And so, yeah, so I think it's just to emphasize that time is crucial, and one shouldn't delay these investigations. Other factors that increase your yield are a history of an overt bleed, use of antithrombotic agents, if the patient is an inpatient, if they're male and older, and if they have comorbidities like liver and renal disease, and if they've had high transfusion requirements. It's got an excellent safety profile, the main complication being that of capsule retention, but that rate is only about 1 to 2%. And so unless there's a major concern for retention in the sort of setting of either previous obstruction or maybe known Crohn's disease or something along those lines, then there's no need to perform imaging prior or a patency capsule. One can just go straight to your video capsule. And so, as I've mentioned, this is what they recommend, that given its excellent safety profile, tolerability, and potential to visualize the small bowel mucosa, that it should be the first-line examination for suspected small bowel bleeding. And that time is obviously crucial, as I've mentioned, to do it within the first 48 hours, with both of those being strong recommendations with moderate and high quality evidence, respectively. It's not without its limitations, though. So obviously it's purely diagnostic. It's got no therapeutic capabilities. There's also some difficulty in localizing the lesion within the small bowel, but there are some tricks to try and aid you, aid you in trying to figure out where that lesion is. The one is obviously the small bowel transit time, which is your time taken from the first duodenal image to your first cecal image, and that can guide which approach you use. So an anterogoid approach if your lesion falls within the first two-thirds of your small bowel transit time. Otherwise, a retrograde approach if it's in the last third. With artificial intelligence and things like that, I'm sure we'll see a lot more sort of precision coming through with regards to localization. And there's also other technology or variations of capsules, like this Odo capsule, which has wheels on the side, which actually directly measure distance traveled as it goes through the bowel. Other limitations include the rapid transit through the proximal GI tract. And so you have, it's not as good at detecting lesions in that area, but obviously one hopefully would have done a high quality upper scope prior to performing the video capsule. Device-assisted enteroscopy is an alternative, and this includes double balloon and single balloon enteroscopy. As far as I know, spiral enteroscopy is no longer available due to significant adverse outcomes. And the advantages here is that you have therapeutic options available to you as well. It does, however, have a lower rate of complete examination. It's more invasive. There's obviously potential complications with sedation. It's time consuming, especially if you're going to be doing both antero and retrograde approaches. As I've mentioned, its diagnostic yield is very similar to that of video capsule, and it improves up to 75% if one does a video capsule first and there's a positive finding on that. That also obviously can guide which approach to use when you do perform your device-assisted enteroscopy. There's not much difference between a double or a single balloon, other than a double balloon has higher rates of total enteroscopy compared to a single balloon, but both the diagnostic and therapeutic yield is similar between the two. Push enteroscopy is something that is obviously available to every practicing endoscopist, and can be used when the lesions are suspected to be very proximal. One can appreciate, though, that you don't quite get the same depth of intubation. With push enteroscopy, you get a mean depth of 80 centimeters past the past the ligament of Treitz versus 230 centimeters. Intraoperative enteroscopy, is another alternative. However, it's rarely indicated, and this is only really considered when there is recurrent bleeding, or when other modalities have failed to detect a source, or when one cannot perform the device-assisted enteroscopy without someone or surgeon performing adhesiolysis as well. It has a very good diagnostic yield though, but is associated with quite a high morbidity rate of 18% and a mortality rate of about 5%. Excuse me. So the ESGE guidelines suggest that it is an alternative first-line test in selected cases, depending on the clinical scenario and local availability. Again, time is important and should be performed within the 48 to 72 hours after the bleeding episode. That's a strong recommendation. And yeah, that it can be considered along with dedicated small bowel cross-sectional imaging as a primary diagnostic test when video capsule is not available or contraindicated, but that's a weak recommendation. Other imaging available to us includes barium studies, which were, I think, widely used in the past. And you can appreciate that they were relatively good at picking up sort of mass lesions and even deep ulcerative lesions, but that they would miss flat lesions, and overall the yield is actually very poor, and so they're not recommended at all. Cross-sectional imaging includes CT enterography and enteroclysis. Enterography requires ingestion of a large volume of contrast versus enteroclysis, which is the administration of contrast via a nasoenteric tube, which gives better small bowel distension, but is obviously poorly tolerated by the patient. And you can also appreciate that in CT enterography, drinking large volumes of contrast, if the patient's unstable, that might not be feasible. Also with better imaging techniques, a lot of these overt bleeding episodes can actually be detected without the ingestion of contrast, so just on CTA. And overall, the yield is not as high as video capsule, so 40% versus 53%. But one can appreciate that a CT enterography might outperform video capsule with mass lesions, and as well as obviously picking up extraluminal pathology. MR enterography is not widely used. There's very few studies looking at specifically looking at MR enterography. It's obviously quite time consuming, yeah, so there's not much indication for it, but can be considered in younger patients where you're concerned about the exposure to radiation. But other than that, there's not much evidence for MR enterography at this stage. CT angio is very good when there's active bleeding. So in cases of acute overt bleeding, they can detect bleeding lesions with rates as slow as 0.3 mils per minute compared to conventional angiography, which requires a slightly higher rate of bleeding at 0.5 to 1 mil per minute. And they have a high sensitivity and specificity of 89 and 85% when there is acute and active GI bleeding. They're widely available. They're performed rapidly. But obviously, there's some disadvantages include obviously contrast with and renal failure. Yeah, But they are recommended, as I've mentioned, in hemodynamically unstable patients, they are recommended as your first line investigation. And even when you're concerned for ongoing active bleeding, it can be considered as well. Red blood cell scintigraphy. This is where patients' red blood cells are labeled with 99M technetium. It's able to detect a much slower rate of bleeding, up to 0.2 moles per minute. And it has quite a wide range of diagnostic yields across studies, ranging from 26% to almost 90%. So it's quite varied in its diagnostic yield. And it's sometimes there's one of the limitations include localization accuracy, particularly in the foregut and in the small bowel. So it's not used, it's lower down your investigation algorithm. Specific scintigraphy scans include the Meckel scan, which is your 99M technetium per technetate scan. This has an affinity for gastric mucosa, which is found in up to 50 to 60% of Meckel's diverticulum. Its highest yield is in children, but there's many conditions that can give false positives. So ulcerative lesions, inflammatory lesions, AV malformations, obstruction, intussusception, and areas where there's other ectopic gastric mucosa like duplication cysts. So just to be aware of that. With regards to treatment, we obviously have sort of many options at our disposal. And without going into too much detail here, I think the important thing is to note that that none of them are used in isolation necessarily. One option can lead to another, and you can use combinations of many, depending on the cause, which, as I've mentioned, the cause are quite varied. So what I'm going to do is just briefly go through some of those causes and discuss some of the management options around them. Obviously, there's far too many sort of causes to go into too much detail, and so I'm going to I've sort of selected a few and we'll just go through them so I think what's quite nice, what most of the guidelines do, and a lot of the articles around small bowel bleeding, is they divide the causes between basically the young, so under 40 and over 40, and the common causes in each of those age groups. And in the under 40 age group, the common causes are inflammatory bowel disease, Dieulafoy lesions, neoplasia, Meckel's diverticulum, and polyposis syndromes. And in the over 40, your angiodysplastic lesions are your number one cause. And overall as well, your angiodysplastic lesions are probably your most common cause, but followed by other causes like Dieulafoy's lesions, neoplasia, and ulcers related to NSAIDs. There's also a whole host of rare causes, from vasculitides, small bowel varices, to hereditary things like blue rubber bleb Nevis syndrome and hereditary hemorrhagic telangiectasia, and then other conditions like hematobilia and aortoenteric fistulas as well, to name a few. And so there's vascular, already. I think I've put my previous one on anyway, it doesn't matter. So angiodysplasia, as I've mentioned, is your most common cause in general, and it's mostly found in your elderly, older than 65. It's got several associations. The big one that I think everyone is familiar with is Haydey syndrome, which is your association with aortic stenosis. And that's caused by high stress over the aortic valve, which results in cleavage of these high molecular weight multimers of von Willebrand's factor, which results in an acquired von Willebrand's factor deficiency. And we know that von Willebrand's factor is required for platelet aggregation and stabilization. And so that results in these angiodysplastic lesions. I think there's, from what I understand, there is some debate as to whether it's a causal association or whether these are just two conditions that occur as one ages. But I think in favor of sort of the causal association is that once you replace the valve, that these bleeding episodes and transfusion requirements are reduced dramatically. Other associations include renal failure and patients on hemodialysis, and this is thought to be as a result of uremic platelet dysfunction. And in general, there's various sort of options for management, but the one is obviously endoscopic with modalities like organ plasma coagulation, and there's also one can also pursue depending on how bad the bleeding is, but a supportive or a conservative approach with blood transfusions and iron replacement. There's also other medications like octreotide and thalidomide that have been shown to be relatively effective in reducing the number of blood transfusion requirements and reducing the bleeding episodes. And I think it was the OCEAN trial that was recently published, which looked at octreotide. And there was also another study that looked at thalidomide that was recently published in the NEJM, that both showed positive outcomes, although relatively small numbers. But obviously they're not without their downfalls either. Octreotide is very expensive, and thalidomide has quite marked peripheral neurotoxicity, although the doses used in these trials were a lot lower. So hopefully, not as severe. So hereditary forms of angiodysplasia include hereditary hemorrhagic telangiectasia, or which was formerly known as Osler-Weber-Rendu syndrome. It's autosomal dominant. It's got a high penetrant, and it's actually relatively common, 1 in 5,000 to 8,000 patients, and involves mutations in the endoglin and ALK1 genes, and also the SMAD4 gene. The majority of these patients have a history of prior epistaxis, which predates any GI or visceral telangiectasias by a decade or more. And generally, GI bleeding only develops later on in the 4th or 5th decade of life. So importantly, with these patients, a history of recurrent nosebleeds and a family history is quite important. And then on physical exam, looking for these minute telangiectasia on around periorally, the tongue, the palms, and the palate. And essentially what happens is you have loss of these end arterial, or at least end capillary loops, and you have these end arteries just directly joining a venule, which creates these AVMs. And just a close-up of some of these lesions. Sorry, it's not the clearest picture. It's diagnosed clinically. So it's the Curacao diagnostic criteria, I think you need 2 out of the 4 of those. So epistaxis, multiple mucocutaneous telangiectasis, characteristic sites, visceral involvement, and a first-degree relative. And you can make a diagnosis. There's obviously also genetic tests that one can perform. And then management is just with either monitoring of HB and symptomatic treatment as required. One can perform endoscopic treatment, angiography if there's a large bleeding lesion, and one can perform embolization. And then there's various medications that are being trialed at the moment. Bevacizumab is a vascular endothelial growth factor inhibitor, monoclonal antibody that's showing promise. I've mentioned octreotide and thalidomide. And then soy has been proposed as well. And although only in small numbers, low-dose tacrolimus has also been shown to be rare, somewhat effective. Doulafoy lesions are these tortuous arteries protruding into the mucosa. They're a rare cause of a GI bleed, but obviously can be life-threatening and are a cause for these brisk, massive upper GI bleeds. They mostly occur in the stomach, but up to 10% can occur in the small bowel. And again, management is either endoscopic with angiography or via surgery. This is a very rare cause, but I thought from an endoscopic point of view, imaging, it was quite nice to see. It's this entity of blue rubber bleb nevus syndrome. As you can see, only a few case reports in the literature. Also includes venous malformations of the skin and soft tissues and the GI tract. The bleeding usually occurs in childhood and is associated with iron deficiency. And you get these large protuberant polypoid blue venous blebs, which obviously gives the syndrome its name. And they occur particularly in the small bowel and colon, and one can manage them with band ligation or surgical resection. Small intestine tumors, although a relatively low or rare cause of GI tumors overall, they're quite a common cause of small bowel bleeding, especially in the younger than 50 age group. The primary tumors that one gets in the small bowel include adenocarcinoma, which is the most common. It accounts for up to 50% of small bowel tumors, and then carcinoid tumors as well, lymphomas and sarcomas are the sort of 4 primary tumors occurring in the small bowel. This is quite a nice little graphic which shows the distribution of these tumors. So adenocAs are generally found proximally in the duodenum and proximal jejunum. Carcinoids are generally found in the terminal ileum, and lymphomas in the jejunum and ileum as well, whereas sarcomas are distributed relatively evenly across the small bowel. And then obviously cysts as well. So these originate from the interstitial cells of Kegel. The stomach is still the most common site, but they can occur in up to 35% in the small bowel. And bleeding is usually caused by compression, ischemia, and infiltration of the overlying mucosa. And one manages them generally with surgical resection. And then ulcers, which is obviously quite a large, can be caused by quite a number of things, but NSAIDs being probably the most common, especially in those who take full dose non-selective NSAIDs. It can occur in up to 55% of patients. But one also needs to think of Crohn's disease and infections like TB. But there's a whole host of things, as I've mentioned. HIV itself can cause ulcerative enteropathy. Things like eosinophilic enteritis, there's vasculitides, neoplasias can come in the form of ulcerative lesions as well. We've mentioned drugs, we've mentioned NSAIDs and aspirins, but things like checkpoint inhibitors as well, which are becoming more commonly used in the treatment for various malignancies, and then other miscellaneous causes, things like amyloidosis, can all cause ulcerative lesions. And so obviously management would vary very widely on depending on the cause. And then lastly, in terms of the causes that I'm going to be discussing, is that of Meckel's diverticulum, which is obviously a congenital, it's a congenital disorder, which results from incomplete obliteration of the vitelline duct. And you get, in more than 50% of cases, you get this ectopic gastric mucosa. It's actually relatively common in the general population, but the majority are asymptomatic. There is this male predominance, and it's most common in the young. So in your first to third decade of life is when the most common age of presentation is. And other than bleeding, diverticulitis and obstruction can also occur. And diagnosis is via Meckel's scan, which we discussed earlier, and dedicated SMA angiography, or double balloon or capsule endoscopy. And management is generally surgical. And I'm sure you all remember the rule of twos from med school. Yeah. Okay. So in conclusion, then, I think the main take-home message is that I think are probably most important is having a good approach, but that proper evaluation of the bleeding characteristics guides that approach. In general, video capsule endoscopy is the preferred first line modality after a negative bidirectional endoscopy. And then device-assisted enteroscopy offers both diagnostic and therapeutic options, but it's of greatest benefit when guided by your video capsule. And I think that the management of small bowel bleeding is there's not a one-size-fits-all type of approach. It's in some ways it's relatively difficult, and each case should be managed on individual merits. Yeah, thank you.
Thank you, Simon, for that good overview on quite a comprehensive topic. I'll open the floor to questions, but I'll also make some comments in the meantime while people think of their questions. So I agree with Simon that the definition of small bowel bleeds, or the obscure bleeding, it was well defined before. Although recently they have tried to make it that you should only call it obscure after you've done your capsule, but I don't think that has taken off much. Capsule endoscopy. So I think, Simon, what you were trying to make the point of is 75% of what you could pick up on upper endoscopy. That's the point you were trying to make on upper endoscopy. Yeah. So that's an important point. Algorithms are always good, but it only gives you a framework towards figuring out what to do next. And I think your algorithm must be adjusted to your environment in terms of what you have available to do. Do you have capsule? Do you have double balloon? Do you have single balloon? Do you have a good CT service? Do you have a good MR service? Do you have access to Meckel scans? Do you have red cell scans? All those things. And you can individualize according to what you have available and what your local expertise is. With regard to repeat endoscopy, I have taken a soft approach. Scoping is user dependent, and you can miss stuff. Even the best endoscopists can miss stuff. So I don't mind people repeating. And the old literature used to say up to 25% of people are repeat endoscopy could pick up something. And you can pick up quite lots of unusual things. So Simon, what do you think would be the unusual causes on upper endoscopy that you could pick up, that you should think about?
Yeah, so I think so obviously I mentioned Dulafoy lesions are very
Yeah.
difficult to detect.
Why are they
Other
so difficult?
Why?
Yeah.
Well, they're relatively small. They don't bleed all the time.
Okay.
And
So they are a direct connection between a larger arterial to a larger venule. And we must not underappreciate their significance. Okay. The problem with them is that they're not bleeding the overlying mucosa can be normal.
yeah.
Only in quite the big ones you can see a prominent vessel.
Mm.
Okay. Sometimes you can underestimate the significance of them. Okay. There's been one occasion where I tried to intervene on a Delafoy, the stomach filled up in 3 minutes, and the patient arrested 2 minutes later. So they are not insignificant lesions. So don't take them for granted. Okay, what else would you think about?
Other lesions include you know, if the patient's got a hiatus hernia, Cameron lesions,
So
or
Cameron
Cameron
ulcer is
ulcers.
good. Yeah.
Yeah.
But what's the important thing about those?
What's the important thing about them?
Yeah, to remember. So they're ulcers within the hernia sac, yes?
Yeah.
Do they respond to PPIs?
No, I don't think they do.
No, why not?
I'm not 100% sure, I must admit.
They are based on ischemia, because you're pulling the vasculature up into the chest cavity, and that's causing the ulcer. So it's not acid related at all.
Okay.
Okay. So eradication, all the other therapies won't work for that. Okay. What else?
On
repeat scope.
On repeat scope, yeah. Yeah, I mean, if there's been a history of vomiting, one can miss a Mallory if they're not bleeding a Mallory vice.
So look for, you mentioned it in your talk.
I did.
So look at the ampulla carefully.
Oh yeah. For Haemosuchus pancreaticus or hematobilia.
Hemophilia. Okay, that's an important thing we don't think, because we're going into the territory of rare things. Okay. Capsule endoscopy. So generally speaking, most of the guidelines have aligned now. So the Americans in the past allowed you to do capsule for even obscure GI bleeding. So you could do upper lower and find nothing and do a capsule. But now both sides of the Atlantic has agreed. So in a patient that has iron deficiency type obscure bleeding, you first replace the iron. If they either don't respond to the iron or they drop the HB again, then the capsule is indicated. In the overt ones, capsule endoscopy can be done early on. What unusual thing could you also include in terms of our setting or Africa in terms of pick up on capsule?
So parasitic infections.
So I've diagnosed quite a few on capsule. So worms. So it depends on how your incidence of worms. You may need to consider your investigation of iron deficiency to include maybe deworming a patient and then see what they do.
Yeah.
Okay. I don't think it's an unreasonable thing, but if you have access to capsule, you could do capsule and make the diagnosis that way. Capsule endoscopy, what is the pickup rate? What should your pickup rate be on carefully selected patients?
So I think in sort of expert sort of hands or whatever, in the right patient, I think your pickup rate is I think close to 75%.
So in the best centers are between 66 to under 70%.
Okay.
When I looked at for one of my abstracts at Grosskeer's data a while ago, we were about 62, 64%. So if you are picking up 50% only, that means you probably doing too many capsules and not carefully selecting your patients. Okay. And then capsules, as you said, as a roadmap for your further interventions. Okay, that's another important thing. So double balloon is probably the best. Spirals out because patients died with the spiral scope stuck in a small bowel. Okay, so that's now going off the market. When it comes to other imaging, CT, I think if you're going to do a capsule and capsule is negative, I think it's not unreasonable to do a CT. You don't necessarily have to do a CT angiogram, but a CT, so that could look at pancreatic lesions, liver lesions, any solid lesions. It could pick up other small bowel lesions, including just, as you said, nets. What other lymphomas in the small bowel? specific ones must you think about?
So yeah, so you can get like celiac disease related lymphomas like ETL.
ETL and ITL, that's important ones, okay? So that's
Yeah.
why scans can sometimes pick up all the solid organs and pick up all those rare things. MRs, probably for just and some other stuff. Meckel scan for Meckel's diverticulum, but why do they bleed? Why do Meckel's diverticulums bleed?
So they bleed because of they've got this ectopic gastric mucosa as well.
So they have heterostopic gastric mucosa
Yeah.
that is sensitive to so they are producing acid.
It's producing gastric acid. Yeah.
The Greek acid. So the acid is abnormal in the small bowel, so you don't have your pancreas to produce your bicarb to nullify the acid, so they cause ulceration within the small bowel. So that's how they bleed. Red cell scans, I don't know who uses them, but the literature says they are good for slow bleeds, but I don't think they really work. Other thing with capsules, any red mark you see is not angiodysplastic lesions.
Mm.
I'm sure if you've done the capsule course or you've looked at enough capsules. So as the capsule rotates, and with capsule 3 on the given system, they have a variable frame rate. So as the capsule moves faster, the frame rate goes faster. But you also realize that when it takes a picture, there's a flash which can reflect off your mucosa. So you can sometimes get a red image on your mucosa that's just the secondary to the flash. So everything that is red is not an angiostatic lesion.
Yes.
Okay. So you have to see it sometimes in multiple views to really call it, or unless it's very classical. Okay. So I think that's one of the other small, very important things to do. Hades syndrome, as you said, acquired from bilirubin deficiency. How do you make the diagnosis of Hades?
Well, one would need an echo.
No, so you have a valvular lesion, yes, give you that. You can have an LDH that's up, okay, I'll give you that. So it's actually not a total van Willebrand's level. You actually need to do a functional assay because you're breaking up the large van Willebrand molecules into smaller ones. So if you do a total quantitative value, it will be normal, but the functional assay will be abnormal because you don't have functional units of your van Willebrand's. Okay. Also want to make a comment on, so if you find, so your capsule gives you a roadmap, you form a small bowel enteroscopy of whatever sort. You find your lesion. What are the options for treatment?
Endoscopically.
Yes.
Yes. So I mean, you've got. I mean, obviously, depending on the lesion, but you can potentially clip through with a
very difficult with double balloon because the clip will be too short.
Yeah.
Otherwise, unless you have a colonic clip that is 2.4 meters long.
Yeah.
So that's the other thing with a double balloon scope is 2.4 meters long. So sometimes the normal instruments for up endoscope will not go through. Colonic stuff may just go through.
Okay, otherwise you can do APC, you can use a gold probe.
Okay, so I won't really use gold probe. How thick is small bowel?
Oh, it's quite thin. It's like
about 4 millimeters at max. Okay. If you burn for a second on the APC machine, how deep does it burn?
Not sure, millimeter.
Up to 4 millimeters deep. So if you burn for a complete second, okay, so just be careful how you APC. What is the recurrence rate of bleeding after you've successfully intervened with APC in a small bowel angioectatic lesion?
So I mean, it can the exact number escapes me, but obviously there are various factors that like number of lesions.
No. So you found your lesion, you found your culprit lesion.
I would say close to 50%.
So there's about a 50% rebleed risk at about 36 months. Okay.
Yeah.
Okay. So in the beginning, in my younger days, I used to be very aggressive, do all the capsules, do all the double balloons, burn everything I saw. But with time, I've become slightly more conservative and try to individualize to the patient care. Anything else? So the rebleeding risk, yes. Lymphoma. Okay. Any questions from the floor? Anything else? Any personal experiences from people who've done capsules, who've done double balloon, who've done APC? So I've been involved in a few double balloons that we've burnt, and then I've been involved in 2 late perforations from APC. So that does happen. Small bowel varix, I've also injected a small bowel varix that bled significantly via the double balloon scope. That was quite scary as well. I see no questions on the chat. Any questions from the audience? You can put up your hand and ask a question. Any comments? So as you can see, you have to individualize it for your patients. So if you have a young, fit patient that his life has been completely affected by small bowel bleeds, it's probably reasonable to, because it affects their quality of life, it's probably reasonable to try to intervene, do a double balloon, do a capsule, get your roadmap, then do a top retrograde and then a retrograde to do complete enteroscopy. Final lesions, intervene, but just be cognizant that there is a chance of rebleeding. As the patient gets older with more comorbidities, these are long, tedious procedures with higher risk, higher sedation requirements, which leads to higher complication rates. So in those patients, you need to carefully discuss with your patient the value of an advanced enteroscopy with interventions. And some of them actually opt for the simple thing of just having recurrent iron infusions or transfusions. The only problem with significant small bowel bleeds is if your patient needs recurrent large transfusions, they can develop antibodies. I see Nasif has put up his hand. Nasif, you can ask your question.
Good evening, and thanks, Simon, for that wonderful presentation, and Shiraaz for this oversights, for this insights. My question goes around repeating the capsule in the context of obscure as well as overt small bowel bleeding. So we've done the basics as been outlined. We've done the capsule. Capsule's normal. Patient's hemodynamic stable. We've had a few cases where on the second or third capsule, we've now made the diagnosis. Any thoughts or comments on that? Thanks.
Simon, you want to go for it or must I?
So, I mean, I think it's a, I mean, if you, obviously we've said that, you know, the algorithms are based on a case by case basis and it's just a framework, but they do make, well, they do mention, you know, once if you've had a negative workup and there's recurrence, then a repeat examination is not unreasonable. And so I think if there's, you know, if there's an overt, if someone's not managing with just conservative or supportive treatment, I think then it's reasonable to then repeat a workup. Yeah, obviously.
So I agree with Simon. If there's overt bleeding and it's affecting the person's quality of life, it's not unreasonable to repeat that. And sometimes you do pick it up, especially delaphoids. If delaphoids are not bleeding, you may miss it. And angulous place and ectatic lesions as well can come and go. Simon, so now you see a large lesion or lots of angioectatic lesions on your capsule and you do a double balloon. And so all your lesions were in the first 30% of your small bowel transit time. And now you go in with a double balloon and you see nothing. What could be the explanation?
I guess if the patient is hypotensive, potentially.
So I think that's an important thing because you quite heavily sedate these patients. If you've done double balloon, you to get in quite deep, you need to sedate them quite heavily. If you lower their blood pressure, the perfusion pressure may not be enough for you to see those angioectatic lesions, or they may not be bleeding. There's a question in the
yeah, I was going to comment on that as well with Nasif's question. The question is any comment about the timing of performing capsule endoscopy after overt bleed? And I was just going to, I think, add on to my answer to Nasif was that I think timing is important. So if a patient comes in again with a large bleed, then getting that done within the first 48 to 72 hours, I think is probably going to be your sort of the optimal way forward, but definitely within the first 2 weeks. So not not topping them up and then bringing them back to clinic in a month to see what their HB is, and then deciding on a repeat endoscopy. I think doing it sort of as soon as possible after that episode is going to be critical.
Okay, so I agree. So probably if they are bleeding, you try to do an upper scope or lower scope, depending on what you have available, quick as possible. Then probably, so some people in private do upper scope, lower scope immediately, and then they try to, because the patient takes prep for the lower scope, they can take the capsule at the same time. And that's one way of trying to do it. Simon, have you ever read about provocative tests?
Yeah, so sorry. So I mean, it didn't change much, but I actually uploaded my presentation, the one just before I'd made some changes this afternoon. Anyway, so provocative testing is obviously an option. So that's when one gives an anticoagulant or thrombolytic to a patient in the radiology suite under angiography to try and provoke a GI bleed. And I think it should be done as a sort of last resort when other investigations have failed to reveal anything. It's obviously, I think it also needs to be done under experienced hands, and obviously with full resuscitation capabilities. I've never seen it done. I don't know of anyone who's requested it here in the time that I've been here.
So there's a slightly modified one. So some people recommend giving like Clexane, either prophylactic or therapeutic Clexane, cause some bleeding, and then do the capsule.
Okay.
Which then will increase your yield. I have not personally done that, but I know of people who have done that to try to pick up appeals, so to increase the yield, especially in the second or the third capsule endoscopy, to try to pick up something, and then you can plan from there in terms of what you're going to do next.
But what is the
how
design?
long, how much you give? So I don't know, that you will probably a bit of trial and error. So you want to give something, cause some bleeding, so see overt bleeding, and then do the capsule.
Okay.
To try to pick up to optimize your thing. So Noni's question about angioectasia was smoking. Noni, I don't know. I haven't read about any of those things, unless you give some insights for us.
I think
so there's no further.
Hi everyone.
Yes, Noni.
Thanks a lot.
Welcome, Noni.
Thank you. No, this is just my limited experience, and with those patients that I've read about, what we have seen this side, obviously, just patients with coming with low HPs. I mean, HPs around 4, but with a severe iron deficiency, usually males, and then there is history of smoking to those that I've seen, and yeah, usually they have this small angioectasia, maybe from the duodenum, but I usually we don't have easy access to video capsule endoscopy as such. So once we have seen a few in the duodenum, then we think like that should be the cause, and then we just commit them to recurrent iron therapy. But the patients that we have seen, actually, we transfuse them so far only 1 to 2 times a year. Really, it's not that common. I mean, we don't do much for them.
Yeah. So I think, as Noni said, if you have somebody even with confirmed angiostatic lesions in the small bowel and you can't do much, a not unreasonable management plan would be to give them regular iron every 2 or 3 months. There are some patients that we've given iron to regularly without them being symptomatic every month to prevent admissions for transfusions. So I don't think that's an unreasonable plan of action, especially if you're a patient, because some of these patients, after doing 3 or 4 upper scopes, 3 or 4 lower scopes, a few capsules, they become a bit reluctant to have further invasive investigations, and they would rather take the conservative route, and that's not incorrect. If you look carefully at this literature, the small bowel bleeding in terms of angiostatic, the mortality rate is very exceptionally low, almost negative. So that's not an unreasonable thing. We can probably add morbidity and mortality to the patient if we do too aggressive endoscopy. Okay. If there's no further comments and questions, I would like to thank Simon for his excellent presentation. I would like to thank ECHO University of New Mexico and the ECHO India team for their support. The recordings of this talk will be available on the Gastro Foundation website. And again, thanks to Gastro Foundation. And lastly, I would just like to say good luck to our candidates writing this Thursday their Gastro Certificate exams. Thank you very much all.
Thank you.
Thank you, Simon.
Thank you.